We've tried to leave 30 minutes for discussion so that we'll have an opportunity to try and think about how to implement some of these ideas. And I'd like to suggest there's two ways to implement them. We all walk away as professionals with ideas of how to implement them when we get back home. But the synergy of this group to create an international model for how to do this really has great benefit to create the kinds of cultural change that we're talking about. So we've heard about competencies go beyond traditional disciplinary skills, that they require some type and level of community immersion, where the community has a role as both educator and evaluator of our students and our faculty, that it requires preparation of interprofessional health workers who are comfortable working across the edges of their cultural boundaries, both between disciplines and within communities. We haven't talked a lot about an issue that's near and dear to my heart because I work with a community. What we found is we do a great job preparing students to be health workers and work with individuals. We do not do a great job in preparing students to work with communities and populations. And so I'm confident in saying our OT students always pass their exam, but they don't always be successful in working with a community or a population. The other piece we didn't talk about, I've not heard it mentioned today, is the role of extra and co-curricular activities in the education of our students in addressing health equity and health disparities. It has to be more than curricular. So please, we invite questions, discussions, comments, and challenges from the audience. I'd ask that you, if you have a particular person you'd like to address a question to do that. Otherwise, if you address it in general, I'd welcome everyone to participate in the discussion.
Elena Rios from the National Hispanic Medical Association. My question was to Jennifer. Well, thank you both, but to Jennifer, you mentioned the importance of cultural relevance, cultural sensitivity in your longitudinal competencies. Could you just maybe highlight the type of activities you do that are culturally sensitive?
So when I talked about the integrated curriculum as part of this project, what we needed to do was bring groups of students together to learn about not only the community of interest that was part of this project, but also all communities of interest, and the fact that cultural groups are not just about race and ethnicity, that it's about every person that's out there. And so that 6-hour curriculum, and the first rollout that we had was with our PA students, our nursing students, and our OT students last summer, included specific competencies that were part of the education, and those were surrounding not only the community of interest, but also cultural humility, thinking about cultural sensitivity on a continuum, self-reflecting first, and working toward awareness, sensitivity, knowledge, and you know, competency and proficiency are something that are out there, and in my mind, not really achievable, because we're always exposed to new groups and new experiences. And so it was bringing a group of students together, not dissimilar to this room, at tables, and not talking at them, but sharing experiences. My colleague that actually is heading that arm of the project up is actually here today, and I would actually invite Shelley Cohen-Conrad to talk a little bit about it at a mic.
So I think part of the question is to address how we support this integrated, integrated curriculum, which, as Jennifer referred to, is really difficult logistically to put together. But I would say, because the culture we have developed over the last 8 or 9 years is really one in which our faculty supports this kind of process, we got them to integrate it into the curriculum. Now, the curriculum is supported by an environment and culture that has multiple opportunities for the students to engage in extracurricular activities. So, for example, we run an event series that every Wednesday we bring in speakers and we do activities with the students, all related to health disparities, social determinants of health, other areas where we're reinforcing these ideas, and we do it together as teams. So a beautiful example of that was when our community health outreach workers came and we did a World Cafe. So that students from the different professions went around and learned about and from each other both what they do, but also how the community health worker is an essential part of that team, moving from interprofessional to a broader model of who is on the health team. And that may be someone who is trained professionally, may also be anyone. It may be the pastor in the community. It may be, you'll later talk about the law enforcement. So that's an example of how we bolster that as part of the culture. We also have interprofessional service learning projects. We have one at the community jail that has been highly successful. The Channels Project and Jen's work has really inspired all of us to create opportunities for this kind of learning. And the last thing I'll say is that through our Center in Interprofessional Education, we offer students mini grants if they are doing interprofessional projects. And so they're now working together in a research environment. So we're trying to touch on everything, again, inspired by the work of Jen and all of us in this room. So thank you.
And then here.
This question is for Jennifer and anyone else on the sitting at that table. How do you, give us more specifics on the participatory role of the community in setting up your community experiences?
So as far as the community goes, and the slide isn't up there anymore, but the slide that had the service delivery arm, the Riverton Health Center is a clinic that we implemented at a housing authority site in the city of Portland that is home to 650 immigrant and refugee families. One of the problems with that housing authority site is it's on the outskirts of Portland, and so access to healthcare was very difficult for folks out there. And so what we did was we built a community-based clinic that is a satellite of our local community health center. And we did a formal needs assessment out there, asked the community what they wanted, and right down to decorating the clinic with artwork, with colors, and with services. And so the public health activities that were at the bottom of that structure are public health activities that the community informed us that they wanted. And, some of them range from, our immigrant and refugee female patients. A predominant problem is back pain. And so we have implemented back pain clinics with our PT department that include students and community members. Some of the community members wanted a Zumba class. So everything ranging from really targeted health approaches to wellness activities, cooking classes, a number of things. Does that answer your question?
Maybe I would like to share how we do it in the Philippines. The question, right, is how involved is the community in terms of setting up the community experience of the students. So it begins, the community is very much involved, even from the beginning, from recruitment of our students. They are the ones who actually select the students who enter into the program. And when they come to the program, for their community experiences, selection of the communities that is not done only by the school. We involve the Ministry of Health and we involve the local government units. So what do the local government units do? They are the ones who actually select the areas where there is a need for health workers. And our students literally live in the communities during their entire community experience. So they live with foster families. The selection of foster families is also done by the community. So the rural health staff, as well as the local leaders, select who are the foster families where the students are going to live with during their experience. And all the other activities going through assessment, all those 5 competency areas are actually done with the community. Assessment of community needs is done with the community. It's participatory with the community. Healthcare, provision of healthcare is done also with the local health staff, and also we involve also traditional healers in the community. And so everything is done together with the community, from selection of students, from selection of training areas where our students should be. The community is involved, to implementation and evaluation of programs and projects in the community. The community is also involved. They do, instead of the students doing the evaluation, we get leaders in the community to do the evaluation of the projects that were implemented while the students were there. And then the students basically facilitate the evaluation process.
I'll just add too that they haven't talked about, we actually participated in a radio show, and the radio show was an opportunity to reach people that we would not normally see. Communities have gatekeepers like everybody else that we know, and we wanted to get to the people beyond those gatekeepers. So the other thing we did was pair our students with a community member, and they went door to door through this rural community, talking to community members about what they saw as the needs. I have a question over here.
Zorae Talib. I'm from GW, but also work on a project called MEPI, which is the Medical Education Partnership Initiative, which works with about 24 African medical schools. And all of those schools, in trying to scale up their efforts, have invested in improving community-based education. And whether it's in MEPI or with the teaching health centers, what I see, or what an observation is, that to scale up community-based education requires resources and a partnership between education and service. And what often seems unmeasured, because when medical schools or academic programs send their students in the community, they measure the students' reactions, the students' performance. But what often seems unmeasured is their contribution to improving the health facility. And when you go to Uganda or in the community health facilities, they tell you, when the students come here, we have shorter wait lines, we do immunizations, there are inpatient services when there are previously not inpatient services when students were not here. So I was very happy to hear that you, actually in the Philippines, you mentioned that you've reduced infant mortality, maternal mortality, and you mentioned that you have some indicators, Jennifer, in your evaluation metrics. So I wonder if you can elaborate on what you're measuring in terms of the contribution to the health facility and the health outcomes of those communities, which ultimately becomes a starting point for a conversation with funders, with the Ministry of Health, the Ministry of Finance, who you need to scale and sustain these programs.
It's interesting that you asked that question. One of the things that, and this award from HRSA was the first one, this interprofessional, it's through the Bureau of Nursing, but it was the first interprofessional award. And they, the evaluators at HRSA asked us a year into the project to sort of change our evaluation framework and start to think about triple aim. And so we all of the project awardees had to sort of change gears with evaluation. And one of the slides that I had up, we're really looking at, on the service side, and again, it's multifaceted because we've got this education, training, and service arm. But on the service side, we're looking at utilization reports and understanding that with this particular population, things might look more expensive before they look cheaper, because we're talking about a community that might not have previously accessed health care, or on another level used the ED for seeing a provider. And so things will probably look a little worse before they look better, but basically using utilization reports, EMR, and CAPS for satisfaction. We're also using another tool developed by Barry Duncan, that it's a visual analog scale that's only 5 items, and it was very easy for us to translate. As many of you on the service side know, CAPS is what, 7 pages long? So trying to implement that with our community health outreach workers, trying to implement a CAPS scale with a person from another language, it is very burdensome and survey fatigue. So does that answer your question? Thank you.
I'd also like to share what we're doing in terms of evaluation. We actually do two different evaluation. One evaluation we do for our students is we evaluate what our students have learned. That's one area of evaluation. But at the same time, since they're working within the context of communities, we also evaluate what is the effect of our students on the health indicators in the community. We don't identify separate health indicators. We usually use the same indicators of the Department of Health. Like when our students go to the community, have they been able to increase facility-based delivery? Have they been able to increase number of deliveries handled by skilled birth attendants? So we basically use also the indicators of the Department of Health in evaluating the effect of the presence of our students in our community. In addition to those indicators, there are also what we call community identified indicators, because when our students are there in the community, they develop a community health development plan together with the village council. And so based on that, they also have certain evaluation indicators which the community wants to see at the end of the stay of the students there. They have certain projects. So these are added indicators that we look into at the end of the community experience of the student. And then if they stay there for a straight 2 months or at the end of 1 year, they have what they call a municipal exit assembly, wherein different sectors of the community are invited, and the students as well as representatives of the community present the output of the joint efforts of the students as well as the community during the entire community experience.
I have right now 3 questions over here, starting here and then moving here for the 4th.
First, thank you so much, Jose and Jennifer, for fantastic presentations, giving us hope that we can start from scratch, we can blow things away, and we can really think creatively about how we can develop those kinds of programs. So thank you for sharing that. So my question is to Jose particular, and it's 2 questions. One of the things that we are concerned about here is how to support education of students. So how are the students supported in terms of tuition and also living expenses at each one of those levels? The second question is related to, we prepare people here for national licensure exams. And so tell us about if there is a standard national licensure exam, and do the students pass it or not?
Okay, so the first question is, how are the students supported into the program? The students, all our students actually are from the communities. They're nominated by the communities. They come from depressed communities, and they fall in the low income bracket also. Part of the philosophy that everybody's universally educable and to increase access to health professions education. And also we believe that a student who comes from the community is most likely to come back. So they come from disadvantaged groups. So how are they supported? They are provided by scholarships by the university. So everybody in the school is a scholar actually funded by the university, or they may be funded by a non-government organization who has a community that needs a health professional. And since this is a project that was jointly entered into with the community, they are nominated by the community. So when they come to the school, they have a paper we call a village resolution, wherein the community pledges to support their scholar during the training. So aside from the scholarship the university gives, the community provides a measure of support. So it may come in the form of allowances, cost for uniforms and other things, which is supported by the community. And the community or the NGO also has the commitment to employ the scholar after training. We have what we call a return service obligation for our scholars, which was started by our unit, which is part of the entire University of the Philippines, which has now been translated into a university policy. So all students of the university, health professional students for that matter, are required to render service for a certain number of years in the community after training. So it's scholarship in exchange for service, actually, that we're doing. And then the second question was, do they pass what type of licensure exams? We only have one licensure examination in the Philippines. There's a national body known as the Professional Regulation Commission that administers all the exams for the health professions. So our graduates, even if they're from an innovative program, take the same licensure examination. We, as far as midwifery, we are the #1 school in the country. We have maintained our status among the top 5 midwifery schools in the country. We get that award every year. Nursing, they also pass. It's usually ranging to above 80%. And medicine, in the early years, we had difficulty because it was largely community-based, and our board examination in the Philippines was very clinically oriented. But in the past, how many years, which I served as dean, we have improved our passing rates. It fluctuates. Sometimes we have 100%. Sometimes we have less than 100%, considering that we're happy with that, considering that our students come from disadvantaged communities. And when they come into the school, we don't give an admission test. Instead, we give a diagnostic exam to identify their learning difficulties so we can classify who are the fast and slow learners. And at midwifery level uptake, where everybody starts, we even have admitted students who have had comprehension levels of grade 4, but we've succeeded in making them go through college work. As we said, we believe in universal educability, although not everybody will become a physician. Maybe some will just have to work as midwives, some as nurses, some will become physicians, depending on the need of the community. And so we've been awarded, our strongest program is midwifery. And then, but what is very important for us also is the objective of the school was to train health workers who would stay and serve in the country. For our medical graduates, we have a 94% retention rate. Overall retention rate for all professions, 85%. And for that, we received actually what is an award in the Philippines, which is known as the Presidential Lingkod Bayan Award. Lingkod Bayan means service to the nation. It's the highest award for service to the nation an institution can receive because of our high retention rates and our innovative program.
Next question.
Another follow-up question on the Philippines, because that's a wonderful model. I particularly want to emphasize what I love is the ladder over somebody's lifetime and the social accountability that's built into that. And my question is, what's the number of years experience you have with that, and what happens with social accountability? How do you actually work the social accountability when people have been a midwife, have gone through, and then are thinking about going up to the next level? How does that play out? Is that a choice the individual makes, the community makes? And exactly how does that happen when you're playing off the individual versus the community at that level?
Okay. First, how long has the program been there? The program has been there since 1976, and I have worked with the program for 32 years. We're 37 years old. I've been with the program for 32 years. I was there in the first 5 years of its inception. And in terms of choice, how do they move up to the program? For one, to be able to go up through the ladder, there are 3 people that should say yes. First of all, the student should say yes, that they're interested in progressing through the ladder. They would like to become either a midwife, a nurse, or a physician. The second component is the community should say yes, because we don't have walk-in students in the school. Every student that comes to the school is tied up with a community that nominated them. So every time they come to the school, they must have a nomination from a community who needs a health worker. And so to go through the next level, to go through nursing or medicine, they must get another endorsement from the community that sent them. So for midwifery, it's the village level. When they get to nursing, then it's the municipal level, because nurses, they have a bigger scope. And then when they get to medicine, then we need an endorsement of the province, because they can work aside from the village that they came from, they can work in other areas in the province. So we need the provincial endorsement. In other words, the student should say yes, the community should say yes. We have experiences wherein the community said no, and so the student had to stay on and serve as a midwife. But after 13 years, no, then she came back for nursing. Then after 13 years, she came back for medicine. She had to serve her community first as a midwife for so many years. And then later they said they needed a doctor. So she came back, finished medicine. So now she's now a physician. So they can move in and out of the program at different points in time. And the last yes should be the faculty. So it's not an individual choice.
There's a question here.
Following on the Philippines, and first of all, congratulations for such a wonderful program. Some years ago in the Network to Opportunity for Health, we had one of your students, third-year students, as a keynote speaker. It was the most mature and the most wise student I ever met at that age in training, and I saw a lot all over the world. So you see that you are really able also to give them the skills, the capacity, and the wisdom to really behave in an appropriate way, also as future professionals. But if I understand you well, the limitation of a medical faculty and training is not within the institution, but you interact with society. The idea, if you want to make a new type of health professional, that you have to change your chief executives. That's a wonderful idea, because now we retrain people with other competences, but they come into a health system that's not prepared to receive them. I think that's a wonderful idea that you involve really also the change. So I'm thinking, looking at that Institution for Health Professional Education and medical faculties, that they should become a new type of institutions with a social mandate, and an institution that has a mandate to contribute to social change. I think that is the fundamental question that we are facing when we are taking our involvement towards the community seriously, that we should be actors as medical faculties, institutes for health professional education, to contribute to equity, to social justice, to relevance, to sustainability of our training. And that means that our staff, we should assess them in another way. They should be encouraged to participate in the community meetings, to contribute by giving advice for political change and legislation, and to assess their work not only with the so-called scientific impact factors, but with the societal impact and the societal relevance they contribute to. Do you have put in assessing and stimulating your faculty in your institution some measures that stimulate them more towards that direction? Because I think you need really to orientate them towards other goals and ends than the traditional things that we use in a medical faculty and an institution.
That was a difficulty in the beginning, even me, because I was traditionally trained. So when we recruit faculty, that is an important component, orientation of the faculty to the innovative program. And so there's a lot of service orientation to the faculty, that this is what we're doing, this is our mission. We pound in the mission and objectives of the school so that we don't divert from what we intend to do. So faculty orientation is very important. And we also immerse the faculty in the community. Like in my early years, I used to sleep with the students in the community also. If my students are in the community for 3 days, I'd sleep with the students in the community. Because when you're in the community, you can't say, we'll meet at 2 o'clock. The people are available at 9 o'clock in the evening. So we had to hold our meetings at 9 o'clock in the evening with the community. So we let the faculty go through community immersion at the same time.
Well, I regret to tell you that we are out of time, so I encourage you to meet with our panelists out in the lobby. Perhaps the most exciting piece of this today is the acknowledgement of all of us that we need innovative ways to prepare students, communities, faculty, and our universities to do this kind of work. It means repackaging our curriculum, and it means coming up with new methods of evaluation so that we can be fair and ethical in the way that we work with our students. Thank you, and look forward to this afternoon.